Yeah, hello everybody, and welcome to our webinar on tuberculosis of the lung. As you are certainly aware, tuberculosis is still a global problem, as almost 1/3 of the global population is infected with Mycobacterium tuberculosis, and almost 9 million patients get infected per year, and 1.5 million die from this disease. The strongest risk factor, and this is mainly important in Africa, is HIV. And Africa is also the main focus of tuberculosis, as most of the patients with tuberculosis live in Africa and in southern Asia. And my focus will be on the radiological course of tuberculosis, on different manifestations of tuberculosis. So don't expect too many clinical information from me, but we have our colleague from the internal medicine here who will help me with all the clinical issues. The primary focus of tuberculosis, the primary site of infection, is in almost all of the cases the lung, at least in Europe. In Africa it is sometimes a different story, but also the bowel tuberculosis is still prevalent. The disease occurs usually in childhood, but we see more and more patients with primary tuberculosis, which is the first infection of tuberculosis in the adulthood, and in many cases the disease remains asymptomatic. Maybe you can talk about a little bit on the clinical symptoms of tuberculosis from the primary infection.
The primary infection, as you have already shown, is asymptomatic. There are no signs of tuberculosis. The typical symptoms are night sweat, weight loss, and almost a low-grade fever in the most cases, and therefore most often primary infections are not detected, and yes, and they're asymptomatic normally. Yeah. The classical symptoms are more likely to appear when the tuberculosis reactivates. I think you will show,
I will show
some pictures.
Yeah. And the good news is that in almost all of the cases, more than 90% of the cases, the tuberculosis heals with some scars, some calcified granulomas, or also soft tissue nodules in which some mycobacteria may survive. We call this latent infection. In only 5% of the patient, the disease shows a progressive course, and this is mainly seen in patients who are immunocompromised, so mainly HIV-positive patients or immunocompromised patients for other reasons. And in 5% we see a reactivation of the disease, which we call post-primary tuberculosis or post-primary TB, and this disease may occur years after the primary infection. It occurs in adulthood and is mainly, frequently, a reinfection. We see also some exogenous infection, some new infection in the patient who had already primary tuberculosis in his childhood. The book is still open. We have to learn a lot about post-primary tuberculosis in the years to come.
The risk is much higher for children to have progressive primary infections, which I think is very important to notice. And the risk is much higher during the first 2 years after infection. After the 2 years, the risk is maybe half of the patients that are infected show symptoms, show active TB during the first 2 years after infection. And the other 5%, as you have shown here, the problems occur during the lifetime after the 2 years of the primary infection.
So what makes tuberculosis so special for us radiologists and also for the clinical partners? Tuberculosis may involve any organ. We just learned it mainly occurs in the lung, but it may involve any organ, and in organs besides the lung, it's a diagnostic challenge, as tuberculosis may imitate a number of diseases, and the radiological manifestations depend mainly on the immunological situation. So tuberculosis in an HIV-positive patient looks different from a tuberculosis in child or in elderly patients. So what is the role of chest radiography in tuberculosis? It is still the cornerstone in diagnosis of tuberculosis. We need chest radiographs in the diagnosis of tuberculosis, and it is essential for follow-up examinations, and it's helpful for the assessment of treatment response and disease activity. CT is performed in patients with tuberculosis, but it is mainly limited to patients in whom the diagnosis of the disease is not possible by chest radiographs alone, or for the evaluation of complications and the assessment of treatment response and disease activity, mainly here in patients with multi-drug resistant tuberculosis or extensive drug-resistant tuberculosis. So let's move on to the first case. This is a chest radiograph of a 9-year-old pupil. This examination was performed due to an environmental investigation. The patient had an open tuberculosis, and the chest radiograph was only performed in one plane because this is a young patient, and in order to reduce the radiation dose, we just performed chest radiographs in this question just once in one plane, and the radiograph was performed about 2 months after the exposure to tuberculosis. So the challenge is now up to you. What do you see on this chest radiograph? Is it normal, or do you see any abnormal findings here? Do we get anything from the chat? Nothing so far, so maybe
this is a very difficult question.
Sure, otherwise I wouldn't show you. It is frequently very difficult because the changes might be maybe very subtle.
Very subtle.
And you have to look very carefully. You have to look systematic on the chest.
So always you have to look at the soft tissues. Of course, you have to explore the skeleton. I would wonder if Helmut suggests us a bone case at first, but finally, always we have to look at the bones. We have to look for pleural effusion. So the pleura is very important as well. Of course, the vessels and the lung structure.
There are two findings. Let's say there's an abnormality at the left hilus.
Yes, and the answers are right. The suggestion is right. What we see here is quite a prominent hilum here. It is very subtle, I agree, but this is as it is in chest radiology. Chest radiographs are frequently very subtle, and almost 15% of all chest radiographs in tuberculosis are completely normal. So the most prominent finding in this patient was this prominent hilum on the left side. This is the corresponding CT scan. The CT scan was performed because all other studies remained negative, and the physicians wanted to confirm the diagnosis of tuberculosis. One may argue if this was necessary. I highly doubt, but it provided us with these nice images. You see here these bulky lymph nodes. Here is a number of lymph nodes. You see these lymph nodes are hypodense, meaning dark in the center, and a little bit less dark on the outside, which corresponds to a centrally necrotic lymph node. And in the lung parenchyma, and here in the left lower lobe, we see this nodule, which has a air-containing area here in this ventral part of this nodule, which corresponds also to the necrotic nodule. And this chronic nodule, this nodule here, corresponds to the primary site of infection of tuberculosis in this patient.
Can you show, do you see the lesion here in the X-ray also?
No.
In the former X-ray?
No. To be honest, even if you are going back, you don't see it very. You can't say you see it if you know that it's on a CT scan, but even going back to the chest radiograph, I highly doubt that anybody would give this in advance. So this is a very typical manifestation of primary tuberculosis of the lung, and also the location is very typical. Primary tuberculosis mainly occurs in the lower lobes and middle lobes or the lingula, so it does not occur in the upper lobe. It may occur, but most frequently in the lower lobes or middle lobe. And we frequently see a consolidation, which is called the gone focus. In many cases, and in children, in almost all of the cases, we see some additional lymph nodes, as also shown on the CT scan in this patient I already showed you. And the combination of this consolidation and lymph nodes is called the Ranke complex. In some patients, these lymph nodes are so big that they lead to an obstruction of a bronchus. It's most of the cases it's the middle lobe bronchus, and the only sign of tuberculosis we see on chest radiographs then is an post-obstruction atelectasis of the middle lobe. In some cases, up to 20%, we see also some pleural effusion, and as already mentioned, the chest radiograph is completely normal in up to 15% of the patients. So let's move on to the next case. This is a chest radiograph in two planes of a 31-year-old male patient who presents with cough fever, and the symptoms began about 2 weeks ago. And in addition to this fever and cough, the patient complains about severe dysphagia and retrosternal pain. So have a close look at these chest radiographs, and maybe we get some response from our audience. Not yet. And I don't expect too much from the audience because this is very challenging. Maybe Peter sees something.
If somebody is honest and knows a little bit about the case, it is very difficult to find anything in advance. We see the hilar structures in the opposite to the former case, beautifully delineated. We see the vessels in a normal outline, and would prefer to go to other imaging techniques.
Yes.
There's one response from the audience, meanwhile too. So one is that you can see the donut sign.
Yes, great.
And another one, was the same.
Yeah, great. The donut sign, for those of you who are not familiar with the sign, is usually you just see soft tissue here in this ventral region, ventral to the trachea, which is corresponding to the right pulmonary artery. Here's the left pulmonary artery, and down below you should not see that much. There's too much tissue here below the hilar region. We call this the donut sign because this resembles a donut with a centrally located bronchus. We performed the CT scan because the patient had severe symptoms, and on the CT scan you see quite an impressive lymph nodes, and also going back to the chest radiograph, look at this, you hardly see anything on this chest radiographs, but if you go now to the chest CT, you see a lot of tissue. You see these huge lymph nodes. These are centrally hypodense, which means they are necrotic, which makes tuberculosis very likely. Not exclusively tuberculosis, but tuberculosis could be my first choice in the differential diagnosis. So the lymph nodes are seen here in the infrahilar region, and also some lymph nodes were seen in the paratracheal region. So due to his severe problems with swallowing, with dysphagia, the patient also underwent a barium study, and the images are shown here. And these barium studies were performed just a few days after the CT scan. So this looks strange now. Is there anybody who has an idea what we see here? Keeping in mind what we saw on the CT scan.
Sorry, as long as participants are thinking of that question, there's one question to the CT scan before. What about the kidney, the left kidney in the CT scan? Is there an illness, or is it just the way we don't see it because it's...
The kidneys were not affected in this patient. It looks a little bit strange on the first glimpse, but if you have the whole slices, the kidney was okay. We did not have any positive cultures from urine, and also other studies were normal regarding the kidney. So back again to our volume study, and if nobody...
No, there are some answers. One is there a retraction, the reticulum? And another one is there is a compression because of lymph nodes.
The idea of retraction, the reticulum is good because most of us learned in med school that tuberculosis may lead to retraction tubercular in the course of the disease as due to necrotic, as due to scar forming. But this is a very fresh, this is a primary tuberculosis, what we are looking here. So there was no time for the forming of a retraction tuberculosis, retraction diverticulum.
What should be added is that the diverticulum has smooth contours, even some kind of detachment of the diverticulum to scarring may lead to a more triangular shaped diverticulum in this area. But this is an irregular contour and is leading in a vertical fashion to the lumen of the esophagus, and looks like a fresh ulcerous or fistulous process.
So I show you the CT scan, which was performed a few days later. And what we see here, this is a contrast enhanced scan. This is the first scan, and this is the non-contrast enhanced scan performed 6 days later. And what we see here is this was this huge necrotic lymph node, and in this place we see some air bubbles now, and the lymph node is much smaller. And the explanation for that is, Peter, you have an idea?
That the material has a gut connection to the esophagus.
Yes, this is something which we frequently see in tuberculosis. This necrotic
material is swallowed.
Is expelled. It finds its way out, and in this case, it found its way out into the esophagus and was swallowed. So this is a rather abnormal case, a presentation of tuberculosis, which is a huge lymph node which expelled its content into the esophagus. But the tubercular manifestation itself, the lymph node tuberculosis, is one of the most frequent presentations of tuberculosis. So let's move on to the next case. This is also a young patient, 24 years old, male, with long-standing diabetes, presents with ketoacidosis and fever. And what are the most prominent findings in this patient here?
I'm very sure that our experts will solve this first attempt to the
second
to this image.
So they are still thinking about the answers.
Yes.
Okay, now we have one answer, which could be upper left lobe opacity.
Yes, completely agree with that. There are some ill-defined consolidations here in the left upper lung region. We just have one plane, so we can't be sure that everything is the left upper lobe, but for sure we know that it is in the left upper region of the lung, mainly located in the lung periphery. Consolidations ill-defined. And in a patient with fever, this was diagnosed as pneumonia. So the patient got his follow-up chest radiograph a few days later, and the patient didn't improve much, but everything got worse. So we have a treatment-resistant infant pneumonia. And what's your idea now? And I can make this story a little bit shorter because we all know that we are talking about tuberculosis. And this is also not an unusual presentation of tuberculosis. Tuberculosis may look like a standard pneumonia, if you call it standard pneumonia. It is in some cases hard to differentiate from a normal bacterial pneumonia, and only the course does show that this patient does not respond to standard antibiotic treatment.
It's also, one might comment that the time period is quite long.
Yes, there were some chest radiographs in between, and I didn't show all of them, so I just wanted to show the most prominent differences now.
Could I ask the question to internal medicine, to Stefan Winkler? How is your impression, how often radiologists indicate tuberculosis when it turns out to be?
It's very difficult to say. I cannot really say numbers or
no, of course not,
figures,
just
but
by impression.
I think it's normally the first radiograph, the first X-ray of the chest is when we see the last one. It's like pneumonia. I think that the diagnosis would have been pneumonia, and not really tuberculosis. And I also think it depends upon the information that is given. Yeah, and as you know, the information is often scarce. Yeah, they just order X-ray of the chest and do not add any information. And I think when we look at this, it's very difficult.
Of course,
I think to write down it could be tuberculosis because it's not that frequent in our country. But when the treatment doesn't help, the antibiotic treatment is not effective, I think there should be some suspicion. Also raised maybe by the radiologist.
Yeah, and in this case, as in many other cases, treatment-resistant pneumonia resulted in a CT scan, which is quite reasonable. I would suggest to do so if you don't have any clue about the diagnosis. CT is a good idea. You can exclude post-obstruction pneumonia. You can exclude complications. And in this case, it showed us this CT scan with these consolidations, which we already knew from our chest radiograph. We see this consolidation is mainly limited to the dorsal part of the left upper lobe, to the apicoposterior segments of the left upper lobe. We see some ground glass. We call this ground glass. Ground glass is it is defined as a lung region with increased density, where you still see the wall of the bronchi or the vessels. So this is ground glass or dense ground glass. This is a consolidation with a positive bronchogram. We see the bronchi air-filled, and we see also some consolidations, some nodular, ill-defined consolidations and ground glass here in the left lower lobe. Are there any questions from the audience so far?
No, okay. No questions.
So you can't make the diagnosis of tuberculosis based on these images alone. You would need some more findings, but it is quite suggestive that there is something going on which is infectious, and knowing that the patient did not respond to conventional treatment, one has to raise the suspicion of tuberculosis. So this was made, and then the patient underwent bronchoscopy, as sputum analysis was not positive for tuberculosis, and bronchoscopy then could confirm tuberculosis. So this is quite a rather typical case of primary tuberculosis. So we move on with this case, a 46-year-old male patient returning from Kenya, and he presents with flu-like symptoms, some upper abdominal pain, weight loss of 10 kilograms, and you see here the lab findings here below. Maybe our colleague from internal medicine would comment what he would think about these lab findings.
Here we see some elevation of the inflammatory signs, which are not specific to a certain process. It could be also a viral infection, for example, especially in combination with the elevation of the LDH, which just shows us that there is some turnover of cellular material, and I wouldn't give a lot to the slightly elevated transferase, which is quite often seen, maybe due to medication or some steatosis of the liver or something like that. And also the pancreas enzymes are just slightly elevated, which do not really help us in the diagnosis, and they just tell us that there is not a lot of inflammation ongoing. Maybe it's a chronic process and it's a slight elevation of enzymes. The laboratory signs that are interesting are the LDH, which might show us that there's some cellular turnover, and but no specific signs altogether. Yeah.
So the chest radiograph, how would you interpret this? Is this something we get from the audience?
There's one suggestion that you see an extraphrenic peak. Atelectasis is on the right side.
This is a little bit too much interpretation. I wouldn't see that because in particular we don't see any loss of volume in the right upper lobe.
We have much fat in this region,
yes.
And this mixes sometimes up. But it is a good observation that it is not really round. But we would think, what do you think? I would say that it's fat.
Yes.
Then another answer is that the right even looks lobular.
Knowing that we are talking about tuberculosis, everybody looks at the hilar region, which is great, but not pathologic in this case.
There are many vessels coming directly orthograph. In this case, on the right hilum, and we can explain it as vascular.
Remember, the patient complained about abdominal pain, so there was not much interest in this chest radiograph, also from our radiologist in charge, and this radiograph was given normal. In retrospect,
there are no effusions, which might be important with the symptoms, but
only in retrospect, if you look here, you see this is too much here. You see some nodules, and that is, but this is on a PowerPoint. Very difficult on a radiograph performed in the bed. So,
but you see that nodules only on the left side, or also on the?
You see them also here, but it's extremely subtle and difficult. Define this as negative.
We could not ask that from the audience because it is the quality in the internet not good enough.
Okay, so we go now to the CT scan, and what we see here is quite an interesting picture. So we see nodules, multiple nodules. All these points here are nodules, and these are very, very tiny, less than 1 millimeter in size, and we see countless of these. And if you look at the distribution of the nodules, you can't really tell where these nodules are mainly located. They are everywhere. We call it a random distribution of nodules. There is some lymphatic tissue here, but this would not explain the hilar changes as suggested by one of our audience. Okay, so we call this miliary tuberculosis, and this is from another patient with this tiny nodules. This is a hematogenous spreading of tuberculosis, which is also one of the manifestations of primary lung tuberculosis. So what is miliary tuberculosis? A hematogenous dissemination. It may occur as primary, also post-primary tuberculosis, and we see these countless, very small and well-defined nodules in random distribution. And the chest radiograph, and this is remarkable, is frequently negative in almost 40%, 30%, or at least 30% in my personal experience. So one other important point here is that patients with miliary tuberculosis are not infectious. The sputum remains negative if it's just and exclusively a miliary tuberculosis, meaning a hematogenous spreading of tuberculosis. There are some differentials, and the most important differential here are other infections such as fungi, which are not very common in our area here. Also, Candida may present with nodules, which are frequently not that many. Also, thyroid cancer may present with miliary image, with a miliary distribution of nodules, but in most of the cases, the underlying malignancy is known, and in extremely rare cases, the sarcoidosis may imitate miliary tuberculosis.
The distribution is hematogenous.
It is a hematogenous spreading of
the only infection that might be quite a little bit similar than miliary tuberculosis would be histoplasmosis.
Yes, this is on the right side. What you see here, this is histoplasmosis.
Because it's the same. Also, when you take out the biopsy and do histology, you have a granulomatous disease. And when you do not find the pathogen itself, it might be misinterpreted.
Yeah.
Sometimes.
Yeah. Absolutely.
There is a question to the patient you showed before,
yes.
And the question is, why was there abdominal pain?
The patient had not only miliary tuberculosis in the lung, but had also a tuberculosis of the kidneys and involvement of the liver and spleen, and it turned out that the patient was HIV positive, which explained this quite impressive course. Any more questions? Okay, so let's move on to a very interesting case. I love this case, and I hope you will too. This is also a young patient. We are talking about young patients in primary tuberculosis, 28 years old, male patient, immigrant from Somalia. Also, this one patient presents with fever since 14 days, and as in the other case, the lab findings are nice, but not very impressive. So, okay, maybe the audience is now primed and knows what to look for. Not yet?
They're still thinking about the answers.
Yeah, good reason, because not that easy.
One answer can be in the left hilus.
Yes,
Yeah.
again,
Prominent.
the left hilum is definitely prominent, and in a patient, in a discussion on tuberculosis, we are pretty sure that this region is involved, and indeed it was involved.
But if you stay a little bit on the plain chest, it helps you. It helps you to detect hilar disease. If you ask yourself if you could explain the hilus as a tree, and if there is something which is not fitting to a tree, like this convex line, which is shown here, that could help you to detect. But we are happy that colleagues in this expert chat were able to do so.
Okay, so this is the region of interest, this lymphadenopathy on the left hilar region. We performed the CT scan. I don't know for what reason, but it is interesting. It turns out that this is the most interesting thing here. So what we see here, let's go back. We see here this lymphadenopathy. We already know this from the chest radiograph. We see these lymph nodes, and you already learned that lymph nodes in tuberculosis are hypodense, meaning dark in the center, and this dark center corresponds to necrotic material. So this is very typical for tuberculosis. In the chest, in the lung window, you don't see any involvement of the lung parenchyma, which is not that abnormal in tuberculosis, that you just see involvement of the lung parenchyma. So a few days later,
there's one question before
yes.
you go on. Is the trachea dislocated to the right side on the chest radiograph?
No, the plane is just not orthogonal to the course of the trachea. So this is due to the
good question,
but it's not. It's definitely normal. Okay, so look at this image here. This is the first chest radiograph we got from this patient, and now a few days later, not that long, the picture changes completely. So this is a picture you have to memorize, because this is something you have to know in your night shift, when you're on call. You have to warn your colleagues if you see an image like that. And why? What do we see here?
question is whether the patient is under treatment already and has been diagnosed already.
I can't really confirm this. I don't know. I simply don't know. But also, this patient was HIV positive, and for this reason, it might be that the treatment for tuberculosis was delayed in order to prevent immunoreconstitution syndrome. So, I'm not very sure. But what about this chest radiograph on the right side? Let's move here.
One participant suggests that this again fine reticular metastases.
Reticular, or I would even go for reticular nodular, because if you look here, there's some nodules. Yes.
Another one proposes that it could be pneumonia.
Yes, it could be. The idea is not that bad, because the obstruction of the bronchi due to the lymph nodes may lead to a post-obstruction pneumonia. But if you see nodules in the patient with tuberculosis, we have to be careful. If you see nodules, we have to analyze the image if these nodules are distributed homogeneously. Is this a random distribution? This is the question we have to ask. And what's the impression of the audience regarding this distribution? No idea behind?
I'm still thinking. So, what are the possibilities?
Maybe you're
random distributions?
Yes, you have to think about the bronchogenic spreading of the disease, because you don't see anything here, or at least maybe there's some fine reticular changes here, but this is very different from here. So this is not a symmetric disease. So it's not mild tuberculosis, or at least not mild tuberculosis alone. And we perform the CT scan, and this is the
There is no answer about the distribution, but another possible answer to the case, which can be perhaps pneumocystis, pneumonia.
Due to HIV, yes, but pneumocystis is not that nodular. Pneumocystis is ground glass usually, and it is more perihilar in perihilar region. We don't see this in this distribution here.
Restricted to the left side.
Yes, it's mainly restricted to the left side. So this is the zoom of these images, and we see some nodules. This is very grainy here. This is not a normal lung parenchyma. So again, I don't know why a CT scan was performed, but I really love it. I really appreciate it, because I can show you now what happened here in this patient. Does anyone have an idea what we see here? Yes. So I would like to.
Maybe the same as we have seen before.
Yes, the same plus.
The same
because what we see here,
yeah.
what you see here is we see very tiny nodules, very tiny nodules in a random distribution here and here. But here it looks quite different. Here we see some bigger nodules. We see an accumulation, a clustering of nodules, and these nodules looks different. They are bigger, and they are oriented. You see it here a little bit better around the bronchi. And this,
maybe it's a combination.
Yes, it's a combination of
miliary
tuberculosis and bronchogenic spreading.
spreading.
And the reason why I can tell you that this is bronchogenic spreading, as you see again here, this is the bronchus. In the periphery of this bronchus, you see these nodules, bigger nodules, ill-defined here, small, well-defined here, ill-defined. It's very hard to describe here the distribution of these nodules. I will come to this back in a second. And this image explains why we see this. This is the first CT scan performed when the lung was normal. Here is a lymph node, centrally necrotic. And here, in this chest CT, you see now that the center of this lymph nodes is dark. This is air. This means that the content of this lymph node was expelled into the bronchi, as first seen in the other case where it was expelled into the esophagus. And here it becomes a problem, because now these infectious agents, these mycobacteria, are in the airways, are expelled by the patient. The patient coughs, and now he is infectious. And this is also the reason why we have to know this form of disease, because we have to call our colleagues. The patient needs a mask, the patient needs a sputum analysis, and as long as we don't know about the sputum analysis, the patient needs to be isolated, and we are responsible that this message comes through.
And this is of utmost importance, really.
So a few words now to this bronchogenic spreading. The material is expelled into the small airways, and the small airways are now filled with this mucus, with this material, and this results in a picture on the CT scan which resembles this budding tree, and that's the reason why we call this sign here tree and bud sign. On the CT scan, this is from another patient, we see these branching linear structures which correspond to these mucus-filled bronchioles and some nodules. And in a special display, we call this the maximum intensity projection, we see this even better. This looks like a tree, a budding tree. This is why we call it tree and bud. This is a sign of a bronchogenic process. It's not necessarily tuberculosis, but if you see this in a patient with tuberculosis, we have to be careful. This patient is most likely infectious. So remember this picture. So let's move on to a next case here. I have lots of cases here. This one is not that difficult. We forget about the lungs. We see many, many nodules here in the lung. But in addition to that, we see something very easy. This is a mini thing here.
There are no answers at the
moment. No answer because it's too easy. Because we see
they should get the time. They should get the time.
Mm-hmm. So now the answer for writing, one is that we see pleural effusion.
Yes, we see pleural effusion.
And another one is that we see pneumothorax on the right side.
We see a pneumothorax with some effusion here, and the pneumothorax was due to a puncture of this pleural effusion. This patient, and this was also proven by this puncture, had a positive pleural effusion. And the reason why this was performed, the patient had apparently tuberculosis based on CT findings, but we could not prove this based on the bronchoscopy. So a video-assisted thoracic surgery was performed, which then could prove tuberculosis of the pleura. And tuberculosis of the pleura is the last presentation of primary tuberculosis I want to share with you. It's a presentation which occurs usually in the first 6 to 12 weeks of the infection. It is usually unilateral, and the effusion is serous and protein rich, and it is in many cases rather a hypersensitivity reaction than an infection. So if we puncture this, we won't get to the diagnosis. In some cases, as in this one I just showed you, we will end up in a diagnosis of the underlying disease. So let's summarize for the time being the manifestations of primary tuberculosis of the lung. The first one is the parenchymal disease, which is presented with dense consolidations, which are mainly located in the lower lobes or in the middle lobe. Even more frequent, especially in the children, we see lymphadenopathy, and this one is usually unilateral. Miliary tuberculosis is only rarely seen as primary tuberculosis, and we see these randomly distributed small nodules, and pleural effusions are seen in up to 25% of the patients, and it's usually unilateral. So let's leave primary tuberculosis and go to post-primary tuberculosis and start with this case here, a very recent case here, a patient who had to get an operation due to an ischemia of the left lower extremity, and this is the preoperative chest radiograph. The patient was completely asymptomatic. No suggestions so far?
So far, there are no suggestions. I think that's it.
Yeah, it's always good to think.
Okay, so we have one suggestion that in the upper lobe on the right side there is an abnormality.
Yeah.
There are bilateral apical opacities.
Yeah.
And in the right lung we have pleural effusion. Also.
Great. So we see ill-defined consolidations, nodule-like here in both apical lung regions. But in addition, we see here that these nodules are not completely dense. There's some central lucencies, and this should raise the suspicion of tuberculosis, of post-primary tuberculosis, and again, this should end up in a telephone call to our referring physician that this patient is most likely infectious, and this patient underwent also, this is the close-up of this apical lung region. This patient underwent then a CT scan, and if you compare here the chest radiograph with the CT scan, you see now here this consolidation, and in addition to the consolidation, a central air, which makes this consolidation a cavity. And here is the corresponding CT scan in the axial slices. And in addition to what I just showed you, this cavity and the apical region, we see some regions here. And this is what I just showed you. This is dream, but this is infectious tuberculosis. This patient needs a mask. This patient needs to be isolated. So first, how dangerous is this patient for us as radiologists, for you as treating physicians on your ward? Do you?
Is infectious, has to be isolated, as you already mentioned, and it depends how many mycobacteria he espouses actually, and of course how near your contact is with him and how long you stay with him in a room. It depends whether the room has windows and whether the sun shines in and so on. Of course, it's very infectious, I think, and I remember that case, and the patient had open tuberculosis and was smear positive in the sputum, and was immediately isolated.
But what should I do as a radiologist if I was the radiologist putting in the IV for this contrast demand scan? Am I in danger? Do I have to take some drug, or do I have to wait? Or what's the situation?
You will be checked in a few weeks. With what measures you will be checked, it depends upon the region where you work, of course. So sometimes you have to do an X-ray, a skin test, or there's some blood tests which can show whether you have been infected or not.
And is it enough some weeks later, or is it important to have a late control too?
Yeah, there are some indications that's good to repeat some of the tests, maybe 2-3 months or later on, because there are late converters regarding the skin test or the blood tests, so-called IGRA tests, which show whether you had contact with mycobacteria or not. This is not really clear what to prefer. Earlier you did the skin test, which is always influenced by the vaccination or contact with non-MTB mycobacteria, and yeah, you have to. The normal procedure would be that you will have an X-ray after 6 to 8 weeks after the contact, and of course blood test or a skin test in addition. And I think the radiologists are informed about such cases.
Yeah.
I hope.
We get informed, and we have to perform chest radiographs usually 6 weeks after the contact with the patient. So post-primary tuberculosis may also occur, as already mentioned, in almost any organ. It most frequently occurs in the lung, but may also occur in the lymph nodes, in the urogenital tract, and in almost every other organ we are confronted with as a radiologist. So post-primary tuberculosis of the lung, and we stick to the lung today, is in most of the cases an endogenous reinfection. It now occurs mainly in the upper lobes or the upper to lower lobes and shows a progressive course in many cases. And the parenchymal changes are first ill-defined consolidations, and then these consolidations get necrotic in the center, and then this necrotic material is expelled, and we see the forming of cavities, and this expelled material is responsible for this endobronchial spreading, and at the end we see some scars and destruction. Here another case with this thick-walled cavity, which is a very typical case of post-primary tuberculosis, and these cavities may also become as big as shown here with a thin-walled cyst. And if you see a case like this, tuberculosis is your main differential diagnosis. There are only very few diseases which make this big cavities. Again, here, this huge cavity, this is not a pneumothorax, it was a cavity, it might become very, very big. Okay, differential diagnosis of cavities, just in brief, it is very important for us as radiologists to remember, and there is this mnemonic cavity, which is, at least for me, helpful to recall all its differentials. We have to know. C stands for cancer, A for autoimmune, mainly Wegener's disease and rheumatological diseases. Vascular infarctions may also lead to cavities, as well as infectious. And here, tuberculosis is the main disease we have to discuss here. Trauma, which leads to lacerations, and the Y stands for young patients, meaning sequestration or cystic congenital adenomatoid malformation, which also may present with cavities. Here, just to recall your differential, we see this cavity, this is a consolidation here, and in CT scan we see that it's not just a consolidation but also a cavity, which involves also the fissure here. There's a transfissural growth, which may occur in tuberculosis, but I would be very cautious if it's so eccentric, the wall of this cavity. But unfortunately, in bronchoscopy, they found some acid-fast bacteria, and this was interpreted as tuberculosis in the patient got TB treatment, and just a few months later, the whole thing exploded, and it turned out to be a small cell lung cancer, not a squamous cell lung cancer. So be careful. Okay, complications of cavities. Also, this is important. One being the spontaneous pneumothorax. This is a patient with these cavities I've shown you before, and a few days later he got some pneumothorax due to the rupture of these cavities into the pleural space. And another complication of cavities is this one, as shown here. Maybe somebody from the audience is a fast shooter and has an idea what we see here. Just concentrate here on the left apical region. So this chest radiograph was not performed to investigate tuberculosis. You see here this ring-like structure, and here some denser, rounded structure. And if you see this, we have to think about this disease here. Is anybody in the audience who has seen this already, who knows what this might be?
No answers.
No answers.
There's one. Myxedoma.
Myxedoma it is. It's a myxedoma. It's a aspergillus. It's a colony of aspergillus which colonizes these preformed cavities, and it's called fungus ball, mycetoma, or aspergilloma. It is a colonization of this preformed cavity, and are usually round or oval, and these are mobile. So if you put the patient on your on the other side, with this round structure will move. So last patient for now, because we run out of time. A 59 years old female patient with rheumatoid arthritis, dyspnea, and coughing, and this chest radiograph is very difficult to interpret. What we see is mainly white lungs. We see that it is like pulmonary process. It's not a pleural effusion. We see this confluent, ill-defined consolidations in both lungs. On the CT scan, We see here that it is indeed mainly pulmonary. We see also some pleural effusion, and it turned out to be extensive exudative tuberculosis, which is a reinfection of tuberculosis. I mean, it might be post-primary tuberculosis. Also possible would be a primary tuberculosis. The patient got this disease because he was treated with TNF-alpha inhibitors, which made him prone to this infection with tuberculosis. And for the experts among you, this should raise our suspicion. This is very dangerous. What you see here is groundless again, and this should raise a suspicion that this patient runs into the danger of getting a ARDS. The patient got also ARDS. This is a very poor patient. She then got treatment against tuberculosis, and as a result, she got a Lyell syndrome. So her skin got off like in a burn patient. So, but she survived at the end. But it was a very dramatic course. Just a few words to TNF-alpha inhibitors. This treatment is a very common treatment now in many diagnoses and increases the risk for tuberculosis up to 7-fold. And as the diagnosis is frequently delayed due to very atypical courses, and that's why we perform CT screening prior to the start of treatment with TNF-alpha inhibitors. Maybe you want to share some experience with this?
With the risk, you show it on your slide, is up to 10-fold, depending upon the type of blocking agent you use or antibody. And now it's standard to screen the patient. You show it also. Screening is done using either skin tests or blood tests, so-called IGRA, plus X-ray of the chest, and when there are some doubts, you do a CT scan. It's very important to say that the screening is negative before starting anti-TNF treatment. It's also very important to follow up the patients, because many patients travel, for example, to Africa, or to regions where with high endemicity of tuberculosis, and sometimes they are infected during TNF-alpha blocking treatment, and then the physicians rely on the first negative screening tests and deny that tuberculosis, or do not think about tuberculosis. That's very important, because nowadays it's quite standard to screen for tuberculosis. And it's very important to say that there is no golden standard for the diagnosis of latent tuberculosis. It doesn't matter whether you use skin tests or blood tests, there is no 100% security that there is some infection ongoing which might be reactivated during anti-TNF treatment. It's no golden standard.
So this slide concludes our presentation, our case presentation on tuberculosis, and I hand over to Professor Pokieser.
So I really would like to thank Helmut Prosch. I would like to thank Stefan Winkler for their contributions. We have learned a lot. Thank you. Bye-bye.